Hi everyone, this is Debrief for case 2. I just want to say good job on working up case 2. I've heard a lot of good things from the facilitators this week and for the discussion sessions. So good job on, working up this case. And, this case, I feel like considered can be pretty complicated. A lot of like acute things happening with the patients. And this is a pretty, realistic case that you might see commonly when you go to your intermedicine abbey. A lot of patients coming in with heart attack, having like hypertensive crisis, and having a lot of infections. So definitely good job on practicing on your skills, working up in this case. So as always, I'm going to be talking about a few things about the case during this debrief. So first of all, I just want to cover the therapeutic aspects first for the debrief. Not a lot of things or muddy points were mentioned by the facilitators. So good job. It looks like, a lot of students are understanding the topics very well. So I'm happy to hear that. But just a few things about some of mostly the NSTEMI and so the hypertension medications. So the first point I want to mention is about the IV nitroglycerin being recommended for the MI, which is, an option. IV nitroglycerin itself is a vasodilator, and that's why, during ACS, MI setting, we would prescribe or dispense to patients the sublingual form of it, right? So it is the same medications, it's just different route, and thus it has different pharmacokinetics and action, right? Because of the form. So the sublingual one, as you could, the patients could have it outpatients, and they can take it when they feel signs and symptoms of MI. And there's like 3 doses max that they can take, right? Which the patients already took the 3rd dose before coming into the hospital. And in terms of the, at least before the current admission. So for the IV nitroglycerin, there's a confusion in terms of recommending for MI. In this case, for those patients, IV nitroglycerin is going to be a good option. One, it can act as 2 different roles, right? The first one is sort of in the MI setting where it will open up your blood vessels and circulation. So because the problem with MI is the occlusions of the coronary artery, right? So we would like to open those up so we can get blood over to the deepest part of the heart, which is the left ventricles, right? And IV nitroglycerins might be able to do that, might help that, right? Because it's vasodilators. The second part, if you're recommending IV nitroglycerin for this patient, is for the blood pressure part, because it is a vasodilator, opening up the blood vessels, less vascular resistance, and this can further reduce the blood pressure in a sense. So that's the mechanism of action, how it can lower the blood pressure. In this patients, the IV nitroglycerin is perfect. It's double dipping in terms of 2 different actions or the 2 different roles we want the medication to have, right? So one is to relieving the symptoms, to sort of like open up the blood vessels due to the MI, and also the reducing the blood pressure because those patients have hypertensive crisis. But I just want to have you guys in mind, yes, it can help with the vasodilation, help with the symptoms of the MI a little bit by opening up the blood vessels. But it's not very commonly used if the patient doesn't have hypertensive crisis. Just because it's a very potent vasodilators, it can drop your blood pressure a lot. So you just want to be careful in terms of recommending the IV nitroglycerin specifically for patients with just MI. You want to make sure the blood pressure is not, it's not like a borderline going to be low, and patients who is having MI, they might go into cardiogenic shock very quickly if, they have been compromising the effect of the infarction a lot, just because, those myocardial infarctions causing the left ventricle not being able to pump as much, right? Because they're not perfusing, and that can drop your blood pressure a lot if it's been compromised for too long. So if you give them another vasodilators, like blood pressure reduction medications, if they're not hypertensive in the beginning to start with, you can drop their blood pressure a lot. So you just want to kind of like see your patients, how they present, and just making sure you're monitoring very carefully. But for this patient, definitely, the IV nitroglycerin, will help a lot for the two indication we're looking for. And it can be the replacement for the morphine, right? And I know like there's questions too in terms of using morphine for this patient, just because the patient has CKD and currently having acute kidney injury, so a lot of students are hesitant to use it because it's clear to the kidney and you don't want to accumulate and causing respiratory depression, which is very valid justification and also concern to have, right? So I'm very happy to hear that, that you guys start thinking about, using medication and making sure it's going to be safe for the patient. So that's a good job for realizing that part. And so in this case, I would say, the IV nitroglycerin is probably going to be the best options for the patients over the morphine, just because all of the things that we are discussing about, right? The AKI and having like double actions for the hypertensive crisis and also the MI. So that would be good. And in the case that where you might not be able to use nitroglycerin, IV nitroglycerin, right? Like for example, if the blood pressure is not, it is low, then where, the morphine might be an option. Like like the sublingual nitroglycerin, as we noted for this patient, has already been max dose, right? So we can't give any more nitroglycerin, and it's probably not going to give you further benefit anyway. So the morphine can be an option for this patient, even though this patient have AKI and CKD. Like we can start at lower dose if there's no other option, right? We want to make sure the patients are taken care of, given the supportive care. So morphine can still be an option. It's not an absolute contraindication. Just want to make it clear to everybody. But for sure, in AKI and CKD, it can accumulate because it's not being cleared as much as in a healthy kidney patient. So you just want to start very, very low, right? So typically the lexicon recommend, or packaging insert recommend, if you have altered renal function, to start at like the 50 to like 75% of the initial recommended dose. So that's about like, 0.5 to 1 milligrams of IV. You can kind of start from there and then just monitor the patient, right? You don't want to give them too much of the morphine, but at the same time, we just want to make sure that they are not going to be in so much distress from the chest pain. And, hopefully it can relieve symptoms, because it can reduce your oxygen demand as well for the morphine. The third point I want to cover is regarding the metoprolol. I heard from facilitators and like other students as well from one section mentioning they want to switch the metoprolol tartrate to succinate. I mean, it's not wrong, but it's not necessary as either, because I know where you're coming from. You've heard a lot about cardiovascular disease and then switching the tartrate to succinate. So that applies for heart failure and reduced ejection fraction. So if you look back into your heart failure materials, lecturers guidelines, the only beta blocker they are recommended or at least have the evidence to reduce your morbidity mortality in heart failure with reduced ejection fraction. Again, the key is failure with reduced ejection fraction. So the 3 beta blocker are your carvedilol, Coreg, metoprolol succinate specifically. So tartrate hasn't been shown to do that, and bisoprolol. And that's why you probably that's where you probably remember it. But for MI, it doesn't really matter if you use tartrate or succinate. It's probably easier for the patients, to use succinate, just because it's the more extended release formulation, right? So you just take it once daily. Versus tartrate, it's the more shorter acting one, so you have to take it twice daily. But it's not necessary to switch somebody's tartrate to succinate if they are stable on it. You don't want to mess with the beta blocker or anything like that. You can just continue the patient on tartrate for MI. So moving on to the clinical pearls, just want to clarify a few things. I think a lot of students are confused for this case. I've got questions as well prior to the case submission in terms of, the heparin protocol. For this patient, the rate has to be increased just because they're not equal for the APTT or the anti-10A, right? And for protocol, you have to increase it. And when you increase it, it will kind of go over the 1,000 units per hour, which is kind of the maximum recommended dose. But it's the maximum recommended dose rate for the initial therapy. When somebody first started, when we first started the heparin dose, you have the units per kilo per hour of the dose. And also you have the max dose that you can go over with, which is 1,000 units per hour for MI. But if patients has already been on it, and they're just kind of adjusting the rate, then you can actually go over the rate. So the maximum rate only applies for the initial therapy when you just started. If you're going to adjust it, you just follow whatever adjustment the protocol have. And in this case, you can adjust it by 2 units per kilo per hour, which will get you to about like 1050 units per hour, which is going over the maximum rate for initial therapy, but it's okay, you're adjusting. And then you're going to be monitoring in another 6 hours once the heparin gets to steady state. And then if it's high, then you just kind of adjust it down again. If it's stable, then you just continue, and so on and so forth. So just want to clarify on how you use the heparin protocol. There is also a video overview on how you use the protocol. So I would encourage you to do that if you're not sure about how to follow the protocols. Ask me questions, by email, if you want to set up an appointment or anything like that, I'm happy to do that. And one thing I want to emphasize a lot in the clinical setting, if you're not 100% sure on something, especially if it in regards to recommending a medication to your patients or to medical providers for their patients, make sure you either consult with somebody else who might be more familiar with it or who might know the answer, or just say I don't know. I really I would like to suggest that you don't give them the answer that you're not 100% sure of. Imagine, right, like if you have a family member or even yourself, right, where you get a recommendation that's maybe you can kind of sense from the recommenders that they're not really sure 100%, you won't want to take it, right? And if like once you've given the recommendation, or if you got the medications, family member get the recommendations, and then something happened for them, right? Just because they don't really do their due diligence to 100%, make sure it's the right appropriate medication that they're recommending, how do you feel, right? So I would really pay attention to your recommendations. If you're not 100% sure, don't give it. Only give your recommendation if you're 100% sure. Otherwise, run through your recommendations with your preceptor, somebody, like a more senior pharmacist, your peers, even maybe they have seen this before, like always double check with somebody if you're not 100% sure. Just to make sure you're not going to give the wrong one. And that comes with a lot of liability. And if something happened with the patients with your recommendation, then you will feel bad as well yourself. So really make sure that the recommendation that you make 100% sure. And then there's also like questions about triple antithrombotic therapy. This might be in the more of the, sometimes for patients who are at high risk, for both bleeding and clotting risk, or, cardiovascular disease, atherosclerosis risk, it can be a gray area in terms of having them on triple antithrombotic therapy, right? Because they're at high risk for bleeding, so you're kind of concerned about it, but then they're also at high risk for clotting, so both are harms, right? If we don't weigh the benefit versus the risk. In this patient, I would say the patient doesn't have any bleeding history. Yes, there's hypertension, there is like age, like he has some risk for bleeding frequently the Haas blood. But when compared to the CHA2DS2-VASc score, right, of 7, if it's the Haas blood is like 3 or 4, there is a lot more risk for the patient, or like there's higher risk for the patient, right, to get stroke in this case. So I would say the anticoagulation is definitely needed. And for the dual antiplatelet therapy, the aspirin and the P2Y12 inhibitor that you're selecting definitely is needed as well. And if you look at the guideline, it's highly recommended. It has strong evidence that the patients needs to be on aspirin and P2Y12 inhibitor, especially after PCI and getting stent. So a lot of times the reasons why we need to put them under dual antiplatelet therapy is because the patient is going to be at a higher risk for thrombosis right after they get stent or right after they get PCI. So PCI, if you look into it, it is a procedure, pretty invasive, because you're putting in a wire essentially in through the circulation, through blood vessels to go into your heart coronary artery to see the occlusions, to see how much they are being occluded, being blocked. And then that procedure, if per surgeon or per the cardiologist, they think that the occlusion is too big, then they might want to put the stent to open up the blood vessels. So those two things, your wiring, the camera that goes, the angiography, the machine, the device that they use for PCI, and also if you put a stent on it, it is a foreign materials for your body. And when foreign materials get into your body, right, first of all, like there's antibody, but there's also a lot of platelets that's going to be aggregating around that device, around that area. So the patients after PCI or after getting stent placement, they're going to be at high risk for thrombosis. And the patient's already having thrombosis, right? That's like part of the pathophysiology for the MI, right? It's the platelet aggregations on top of the atherosclerosis of the cholesterol plaque and everything else. So if, after the procedure of the PCI, after the stent placement, if you don't put them on dual antiplatelet therapy, they might get thrombosis. They might get a recurrent MI. So, and they have studied it, and that's why they're making the guideline making this recommendation, right, of dual antiplatelet therapy. The first year after the stent placement, after the PCI, the patient's going to be having that high risk of thrombosis, and after a year, their risk sort of go down, and sometimes it's negligible. But there's still a little bit of risk, and that's why the guideline recommend to continue the dual antiplatelet for at least a year, and then after a year, then we can kind of sort of reevaluate to see what's the risk for thrombosis, what's the risk of bleeding, and if the bleeding risk is higher than the thrombosis, then you would take off one of the antiplatelet, either the aspirin or the P2Y12 inhibitors. Typically, in the clinical setting, you would take off the P2Y12 inhibitors, but there's also data starting to emerge recently that you could potentially do the aspirin to discontinue aspirin instead, and then continue the P2Y12. So something to kind of think about. And in this patient, I would say the stroke risk is higher, right? CHAS-FAST score is 7. It's, your stroke risk is probably going to be over 20%. That's 1 out of 5 chance that they're going to get strokes, right? So definitely I would recommend anticoagulations in these patients. And in this case, either the DOAC or the warfarin. Right now, for AFib, definitely you go straight to the DOAC instead of the warfarin. Its efficacy is similar, less bleeding risk with the DOAC. And for the MI itself, after the stent, after the PCI, definitely you want to start them on the dual antiplatelet therapy with aspirin, 81 milligrams daily, and also one of the P2Y12 inhibitor of your choice. And except for prasugrel, right? Just because this patient is contraindicated due to this prior TIA. Last one, I just want to clarify, there's one confusion about patients having atrial fibrillations, in the sense where well, this patient's EKG doesn't show atrial fibrillation or atrial flutter, so this patient doesn't have atrial fibrillations. So it depends on the type of atrial fibrillation that the patient have. So if you look at the atrial fibrillation guideline, there's different types. There's paroxysmal, which is sort of intermittent atrial fibrillations, or a permanent one. So permanent, typically, the patient is permanently having AFib rhythm. So if you put them on continuous EKG, they'll be having AFib rhythm continuously 24/7 essentially, right? Sometimes they might have, like some normal, here and there, but mostly they're going to be on AFib rhythm most of the time. But for paroxysmal, it's more like intermittent AFib. So they're not going to be continuously on AFib. There are, majority of time they're going to be on a normal sinus rhythm. And then only if they have triggers, or anything that triggers the AFib, then, they will have AFib rhythm, and then they might have like those sinus symptoms of, AFib, like palpitations, have shortness of breath and stuff if it's like prolonged. So just want to clarify, when somebody have AFib, typically it's paroxysmal. They're not gonna be on AFib rhythm continuously. If they are on AFib continuously, they're probably gonna already have interventions being made, like for example, atrial ablations, just to make sure they're not gonna be on AFib rhythm continuously, which is dangerous, right? If you're gonna be on AFib continuously, and you're not gonna be having a lot of good ejection fraction, having a lot of good circulations, and then when there's like gaps where they're on normal sinus rhythm, and then if there's clot in there, they can get stroke very easily. So when somebody have permanent AFib, typically if they are able to get ablation, then the surgery will, like the surgeon or the cardiologist probably recommend it instead of keeping them on permanent AFib. So a lot of the AFib that you're going to see in the outpatient setting is going to be paroxysmal AFib. All right, and then lastly, a few announcements I just want to ask. I'm still looking for liaisons for Dr. Guerrero, Dr. K, and Dr. Young section. So please, if you have the time, and it's going to be a low time commitment roles, you just, if you hear anything from your sections or classmates, you just kind of share with me as needed, and we'll have a midpoint liaison meeting. Last semester for CB3, it only takes like 30 minutes. So it's hopefully it's going to be 30 minutes, but like up to like 60 minutes. And it's during CB4 class time as well. So not like more than, what you're already being asked for this class. So please, if you have the time and if you're interested in working with me, as I see Dr. Guerrero's or Dr. K or Dr. Young's sections, please sign up in Canvas under discussions. Lastly, I've seen multiple late submissions for case 2. Please note that the submission time is exactly at 12 a.m. and please don't submit late, because it's going to flag you, and the next time it got flagged, unfortunately I have to take off points, right, per syllabus. And just kind of allow a few minutes of a loading, because even if you upload it at like 11:15 or even right at 12 a.m., it might not load completely before then, right? Like it might go over and stuff like that. So that might be why your submission is marked as late, just because it's loaded. It takes time to load for your document. So make sure that you are submitting it, at least give it like about 5 minutes of time to get it loaded completely. Okay. All right. Good job again for case 2. And we'll see you in 2 weeks with another case.